Hello, everybody, and welcome to another Thursday Night Live. I hope you guys are doing great. Thank you for the members for being here live with us. This is actually a Friday recording. So if you're watching this on a Thursday, it is recorded. However, you can write on the comments over here and we try to get back to you if you have any specific questions. Or I always recommend you going to Airway Circle Professionals, our Facebook group. We have 3,500 professionals there. And if you have questions, post them on there because there's always somebody. It's a multidisciplinary group, so there's always somebody who can answer your question. Use that group, use that free resource. Every circle is just a super fun, tight community of people who are just nerds and love to learn about airway and anything related to it. So join us in our Facebook group and our Thursday Night Lives and make sure you are part of our directory. We have over 3,000 visits to our directory every single month. So there are patients from all over the place. By the way, I was just looking at my reach. So the way that I get patients over to the directory is through my myofunctional therapy business Instagram account. And I'm going to show you guys how many people are reaching the last 30 days. 1.9 million. So tons of people see this information and they want to find somebody around them. So they go to the directory. If you guys are not part of the directory, not only you're missing out, but these patients are missing out because they're looking for you. So it only takes a few minutes. You don't have to have a membership. You have to create an account with the directory. It's a different software. But I have a video explaining exactly how to do it over there. Put your information, put your training, and people are going to be looking for you very soon. Many times you don't even know that they are coming from Airway Circle because they will call the front office, make an appointment, and maybe it won't get to you. However, it's an incredible resource and it's very well used. So join us. All right, let me introduce you guys to our wonderful speaker. Today we have Dr. Sharon Smart. She's a senior lecturer at Curtin University and senior research fellow at St. John God Hospital. With a PhD in pediatric feeding and communication disorders, her research focuses on tongue-tie or facial myofunctional therapy, infant feeding, and pediatric dysphagia. An award-winning educator, Dr. Smart plays a role in developing clinical guidelines and training to support children and families with feeding and communication challenges. Today's topic is the impact of tongue-tie and swallowing and the implications for breastfeeding and starting solids. This is such a wonderful topic. Thank you so much, Dr. Smart, for being with us today. Did I miss anything?
I think that's enough of an introduction. That's absolutely plenty.
Perfect. Where do you practice?
So I'm actually based in Perth. I'll show you a map as well in Western Australia.
Oh, so perfect. I can't wait. Go.
Yep, it's coming right up.
The floor is yours.
Thank you so much, Renata. And hello, everyone, and welcome. And as Renata said, I am joining you from Perth in Western Australia. So I am currently, I work as full-time as a senior lecturer at Curtin University. And I'll show you. And in Australia, we like to acknowledge the country and the lands on which we're talking and of the research is conducted, which is the lands of the Whadjuk Noongar people. And if you have a look at here at the Whadjuk, there's Perth on that huge, well, small map of Australia, but that small little southwestern piece of the pie is where we are, right on the other side of the world, 18,000 kilometres away from most of you in the United States. So it is winter over here, and it's midnight actually at the moment over here while you're enjoying your lunch over there. So I thought I'd give you a little bit of a background about positioning and perspectives of where I come from, because, oh, sorry, did you have something to say, Renata?
Oh my gosh, I had no idea it was midnight for you. I'm so sorry.
That's absolutely
our assistant, our Australian speakers have to come on Thursday nights live, y'all, because it's easier for you guys. I'm so sorry.
It's okay. I do a lot of work with my colleagues in the States, and I often have meetings at all hours of the day and night. So it's absolutely.
Well, thank you for being here.
So I am a speech language pathologist, and I did do my undergraduate and postgraduate training all here in Perth in Western Australia. I was a clinician for 22 of the 25 years I've practiced, working in both Perth and in London in the United Kingdom. And I still consider myself a clinician at heart, despite now being in a full-time academic teaching and research role the last only full-time for 3 years. So I do miss my clinical work hands-on, but I'm hoping that by doing the research, I can actually support all the amazing clinicians out there in the community a little more effective using my research and clinical knowledge. So my work predominantly clinically and research is in paediatric feeding disorders, which encompasses infant feeding and with toddlers. And in the most recently, for the last probably 7 to 8 years clinically, in the area of tongue tie. And those who have seen or heard me speak I'm very much an evidence-based clinician and practitioner. So that informs everything that I do. And just some disclosures that I do serve currently as chair of the Australasian Society of Tethered Oral Tissue, and I was formerly the vice chair of ICAP, the International Consortium of Oral Ankylofrenulal Professionals. And I still serve as co-chair of Sirius, our scientific affairs wing, with Dr. Raymond Singh in North Carolina and Professor Rebecca Hill, who's also moved to UNC in North Carolina. And I've got adjunct positions in Malaysia and at ANU. But I work at Curtin. Curtin, I've been there for many, many years. So I'm sure many people who are going to be watching this know all about tongue tie, but I always start off for those who are potentially new to the field or have been working with older children and starting to work with younger children. And I like showing them this image about infants and children who have tongue tie and whether you feel either of these children may have tongue tie. And the reality is, by looking at an image like this, we can't actually tell if either of this infant or this child has tongue tie, because when we're diagnosing, we have to look at both the structure, the visual appearance, in addition to the function. And we don't see a video. We can't see this infant or this child eating, drinking, speaking, sucking, swallowing, or breathing. And so it's impossible for us to inform and make a diagnosis in the absence of that information, because the true definition of tongue tie is when there's restriction of the structure of either the lip, the buccal tissue, or the lip or the tongue within the oral cavity, and when movement is restricted. Otherwise, a palpable lingual frenulum is just that. It's just a lingual frenulum unless there's a functional impact. And because I kind of like a little bit of stats, a bit nerdy. A systematic review by Rebecca Hill and her team in 2021 found that the overall prevalence of tongue tie is about 8%, and that was looking at just under 25,000 children in 15 studies, and 7% of those were male and 4% were female. And so it does depend, our diagnosis depends whether you're using a standardized tool or whether you're just relying on visual exam. And so 10%, the prevalence rates were about 10% using a standardized tool and 7% just looking by visual inspection, which really doesn't fit the criteria that we all know. So there's wide variation, and we know that there's a high prevalence rates in infants or children under 1 year compared to adolescents and older children. And boys are more likely to have tongue tie than girls. And so just speaking from my scope of practice as an SLP, according to the American Speech Language Hearing Association and Speech Pathology Australia, we are allowed to identify tongue ties and diagnose, but we cannot recommend surgical intervention. So we can diagnose and label it in our capacity of assessing infant feeding and speech production, chewing, and looking at oral clearance, but we can't actually recommend surgery. And this is similar to IBCLCs. They are able to diagnose, but they can't, there's no mention that they can actually even diagnose a medical condition, which includes tongue tie. So next up, I thought I'd just introduce it back in 2020, I think it's actually last year, 2024, as part of ICAP, we published these both a position statement, which is free and available on the website, but also some practice guidelines that you may be interested, which provides a little bit more, well, it's very detailed, a couple of pages on scope of practice of each of the health professions that are involved in ankylosing management pre and post surgery. So it's worth a read and worth a look. We've got some really nice glossary of terms that you can use when you're working with patients if they want to inform your practice guidelines as well. So there's a position statement on the website. This is full text and free open access that you can use and read at your leisure. I'm sure many of you are familiar with this statement. The ADA, the Australian Dental Association, not the American, released a paper back in 2020. It was quite controversial because some of the content is quite limited in terms of the literature review. However, there was an appendix in here, which I really love. If you haven't seen it, I really like this for talking to families and talking to other practitioners that I work with, is about the flow chart from having an infant referred to you with feeding issues, making your diagnosis of tongue tie because of the restricted lingual frenulum plus the functional impact. And that always, our management should always commence with non-surgical intervention as a first line of treatment. And that could include lactation support for latch optimization. It could be positioning with an occupational therapist or an IBCLC or lactation consultant. Could be using those other tools, parent education, could be working with a speech language pathologist as well. And I think this kind of flow chart, even though it states it's infant feeding issues, we can apply that to children and in fact, even adolescents and adults as well. Some of the feeding supports might be slightly different for our adults. Then before we proceed to actual surgical intervention, doing some follow-up and assessment to see if those feeding issues have resolved. And if not, and once we've reviewed and if non-surgical management has failed, that's the point in time that we consider surgical management. And that time frame between commencing non-surgical management to surgical management with a little baby who's potentially faltering growth and really struggling could be a matter of days, could be a matter of a couple of feeds of giving it a try with some non-surgical, or it could be weeks or months. And there's actually many cases when surgical management is not actually indicated because the feeding issues have resolved, which we all know we've seen and probably witnessed as well. And I can't understate the importance, this is part of our practice guidelines as well, is the post-operative review by the surgeon who's conducting those. And ideally, we've stated in our guidelines that should take place within the first 2 weeks, potentially like 1 to 2 weeks post-operatively, and then a follow-up at between 4 and 6 weeks post-op. And then it doesn't stop there because that child still needs to be followed up by their health professional team, whether that's the lactation, speech, occupational therapy, body workers, osteos, chiros or CSTs, whoever is working with that infant family to see if those feeding issues are resolved. This is a consensus statement which was written by a group of paediatric otorhinolaryngologists, some ENTs, and so it was a really good paper, but it was limited just to medical doctors as well, this Delphi study. And so recently we've actually conducted an international multidisciplinary Delphi study, and thank you to those who may have been involved in this later last year. We're compiling those results, and I will be presenting them at Tongue Time in Switzerland in January 15th to the 18th. So if anyone is coming to Tongue Time, I look forward to seeing you there, and we'll be sharing the results of that. That was conducted with a big international team of health professionals, which representing every discipline involved in the tongue tie team. So my bread and butter is as a speech language pathologist, and my teaching, I actually teach into speech sound disorders and feeding and swallowing disorders across the lifespan. So I love combining my anatomy, physiology and neurology and then applying it to swallowing for infants with tongue tie. So bear with me as I geek out, and we won't go too detailed, but just a bit of a review for those who are unfamiliar with phases of swallowing and dysphagia. There are predominantly 3 overarching stages of swallowing: the oral phase, the pharyngeal phase, and the esophageal phase. And we often break up that oral phase into oral anticipation or oral anticipatory, preparation, and transit. And so the anticipator is when we're kind of smelling foods. I've got a chocolate here actually, my Freddo frog. My previous associations that I love chocolate. So I know just looking at this Freddo for me, it's getting my saliva going. And so all of our negative and positive experiences it kind of prepare the oral cavity and the saliva management ready for that that bolus and that food coming into the mouth. The oral preparation is where we do some mastication. We're actually manipulating the bolus, preparing it, moving it from side to side, tongue lateralization, forming a cohesive bolus, mixing it with saliva. And the transit phase is where we actually commence. We get that contact of the anterior tongue with the hard palate, and the bolus sitting in the central groove, or sitting in the center of the oral cavity. And then as we transit it and propel that bolus, the base of tongue drops, and we get the base of the tongue projecting the bolus against posterior pharyngeal wall down into the pharyngeal phase. And then the esophageal phase, I kind of say that's the ENTs, apart from when it comes back, we get some retrograde movement. So here's a little lovely visual of this bolus of an adult going through the oral phase, transiting through that pharynx into the throat, and then down into the esophageal phase where the upper esophageal sphincter closes. And so just, I suppose, having a look, I love this image on the right where we can see the infant, and we can see here the anatomical changes and how the adult's head and neck region elongates, and that laryngeal area. You can see the epiglottis and the soft palate are in really close contact in the infant. It's more of a protection, but in the adult that really elongates, and there's more active and voluntary requirements for the adult to actually chew and propel, whereas there's a lot of safety features available in the infant's swallowing mechanism. But what's really important here, if we look at these suckling pictures, is the tongue filling in that oral cavity. And there's much less space available compared to in the adult, because the tongue does fill. However, this is a lovely tongue of this infant. We should still get some lovely contact with the mid-tongue and the posterior tongue with the soft palate, which we can see in this infant, with this teat, in this nipple, in this image. And there's a lot of those muscles at the bottom in the throat and the oral cavity that are assisting the pharynx and the soft palate elevation to get adequate feeding and suckling. And so any disruption to feeding can occur in any of those 3 phases, but predominantly in a child with tongue tie, we're really looking at the oral phase, which can obviously have follow-through impacts to the other phases of swallowing as well. So if there is a weak suck because the infant's unable to, well, they can latch, but they're not getting a good seal on that breast or that bottle tissue. There could be some low tone, or there could be other issues why they have a poor seal as well, which can really impact that oral creation of that oral vacuum. And then it can also follow through, have an poor impact on bolus propulsion. You can get kind of a bit of, rather than swallowing a whole bolus, a little bit of piecemeal swallowing. And some anterior oral escape, or it coming out of the front of the mouth if it's not actually suctioned and kept in that oral cavity accurately. So really it's the oral phase of swallowing that's most impacted when we're looking at the the feeding and swallowing. So ankylosing, and we know that it's not just the very anterior part of the tongue, that tip of the tongue, that's really important. As you can see even on this image, it's that mid-tongue and the posterior tongue is just as important, and poor base of tongue movement is probably, in my eyes, probably more important, if anything, than the anterior positioning and contact with that hard palate. And we can see that, and the work of Nikki Mills was, I'm sure everyone's familiar with this because it's 5 or 6 years old now, really changed our understanding about how the structure of that mucosa and the lingual frenulum. And this image here on the bottom, where it has the 1 and the 2, where it has our previous assumption that there was just this submucosal band that was present in every tongue. But actually, we realized that there's different morphological variations there's variability in presentations, that some of us do have a little bit of our fascial underlying with our mucosa, with our lingual frenulum structure. But actually, sometimes we actually have that band sitting within there. And then in others, we've actually got the muscle, like in D, is actually underneath. With that fascial layer and then our mucosal layer. And so there's natural variation, and that's going to impact the surgical intervention that they provide us. This image is courtesy of Dr. Sang, and I love how this picture actually represents each of those presentations and variations in the underlying structure. There's some lovely technology out there that we can use to look at the tongue and look at contact with the hard palate and soft palate and how the tongue moves. This work was by Donna Geddes, where we can see that junction of the hard and soft palate and the importance of the tongue to have really good contact anteriorly to put that pressure and create that vacuum out of the teat, and then also getting that mid-tongue contact with the hard soft palate junction, and then equally the posterior tongue to be able to make adequate contact for propulsion and also for that oral clearance as well. And so in terms of tongue tie, in terms of codes, I know that it's really important for getting funding and things is the ICD codes. And so paediatric feeding disorder does actually have ICD codes associated with it. And so we can say that a child with a tongue tie, in fact, presents with paediatric feeding disorder indicated by, and it could be underlying medical condition is tongue tie. They may have some underlying faltering growth impacting nutrition, feeding skill dysfunction as a result of that oral phase swallowing challenge. And there could be some psychosocial challenges for that family, for that mother and the infant. They could have some maternal stress. They could be infant stress. They could be some breast refusal and other psychosocial impacts. I also wonder long-term about infant mental health and the impact of long-term inability to feed as a result of tongue tie and the impact that has on the family and then the follow-on impact to the infant as well long-term. I think we just don't have enough information about those things at this point in time. This was a fabulous study, and we all love Dr. Bobby Gihiri that he conducted in 2022, where he was looking at the oral phase of swallowing and dysphagia and tongue tie in 3 to 16 week-old infants, and he used the infant feeding system. So this collects objective measures of sucking in terms of like frequency of sucking, amplitude of sucking, how many sucks per burst, and then duration of feeds. And he actually did a randomized control trial and got some control infants who had the surgery straight away, and then some who had delayed procedure, and then measured their symptoms and compared the groups. And he looked at breastfeeding, self-efficacy, reflux, and nipple pain, and found some really, really lovely outcomes, that there was significant improvements in breastfeeding and self-efficacy in the intervention group. and reflux symptoms were much improved as well, and nipple pain were better, but not statistically significantly in the other group. This was also another study that looked at tongue tie and dysphagia. This is 7-8 years ago now, in 9-month-old babies to 7-year-olds, and it was from Parent Report of 165 parents and caregivers of infants with posterior tongue tie. And so they looked at caregiver behaviours and looked at parent feeding strategies and things, and looked at total scores around behaviours of feeding as well. And they found that the problem scores were significantly higher in the cohort of children with posterior tongue tie compared to normal healthy feeding children as well. And there was more negative child behaviours and also parent behaviours as well in that posterior tongue tie group. So she suggested that infants with tongue tie and children with tongue tie often presents with some maladaptive behaviours, and they can be problematic to creating that positive feeding experience with families as well. So then in terms of the pharyngeal phase of the swallow, this was a paper that was published by Brooks back in 2020, and she looked at the posterior tongue base and revealed that the infant children who have poor base of tongue or posterior tongue tie have restricted tongue elevation, not surprisingly, but also lateralization. So the posterior tongue base is not, we always think the anterior tongue is really important if you're getting them to poke your tongue out and move it side to side, but actually the posterior tongue is equally important in this 21-month-old case study to get that base of tongue movement. And that's also really important for that. We call it the oral transit phase, where you're getting that bolus propulsion and making sure there's no aspiration and penetration. Oh, I think it's no surprise there is so much literature out there on breastfeeding challenges and things that you'll see in breastfed babies. Clicking sounds during breastfeeding, losing milk from the front of the mouth. You might see those blisters, the compressional lip blisters. You get those two-tone lips where you've got all the bumps and then you've got the actual pinker lips on the outside. You might get more excessive jaw excursions, little dimples either in the increased mentalis activation, or you get the dimpling in the cheek or the chin, hiccups or gassy symptoms or orofacial. History of poor feeding, coughing on liquids, poor coordination. I think we talked about anterior oral escape, or gagging, choking, and coughing, or tongue thrust swallow patterns. And some of the symptoms that parents might report as well, the nipple pain, you might get bleeding, cracked nipples, latching problems, inefficient feeding, dribble, and falling asleep at the breast, because these poor babies are tired. They're working so hard. So we hear a lot about what happens early on in the first 12 months of life. But for these kids who don't potentially get treated, the World Health Organization suggests that we should be starting to introduce solids at 6 months of age. And so it was developed based on third world countries to ensure sustained and exclusive breastfeeding to 6 months of age. In most first world countries, I think people are really introducing solids between 4 to 6 months of age. And the types of solids has changed over the years. We used to follow a very traditional weaning pattern from, offering rice cereal first of all, and then maybe fruits or pureed fruits and vegetables, to more of that baby-led weaning approach. So some infants are actually experiencing chewing harder foods from their first exposure to solids, rather than a traditional weaning, less independent approach. They're having a more independent approach. And so in terms of the 8 stages of oral development, I think it's really important to also look at what's happening with the tongue movements and the transfer. If we look even at 4 to 6, sorry, this is quite small, is having really good tongue mobility in terms of lateralization and to up and down tongue movements is really important, particularly when we get to that transition phase from smooth purees to mixed textures and lumpier foods between 9 and 12 months of age. And I'm not sure if any of you have seen that asking a child who's 12 months and plus if their child's able, what happened in that transition phase from purees, if they followed a traditional weaning to lumpier textures, we can often see that there's really poor coordination for mixed textures. They prefer kind of drier foods in kids who have got tongue mobility issues. They struggle getting that middle to side back, bringing that food back to the midline, preparing that bolus for eating. We mentioned about the World Health Organization, but I really love this image, which was in Richard Baxter's book, which talks about in terms of the oral, we've got the tongue and that lateral and the lips at the front. And what happens in an infant when they start solids at 6 months, for example, they're just going forwards and backwards with that tongue motion. They have very limited side-to-side movement. However, when they start having those lumpy foods, if we put foods in the side, they'll be able to move it to the center, chew, move it to the center, and then get that and propel that bolus back. But then by 9 to 12 months, we should have this really lovely pattern where they can do some bidirectional, moving this bolus from the center to the side, chew it between the gums, potentially move it to the other side, and then back to chew down. An infant or child who's got persistent tongue mobility issues due to a posterior or a mid-tongue or an anterior tongue tie, you can see that this is going to be really challenging to get really optimal coordination for optimal. These kids are going to tire. They might not be able to chew particular foods effectively. And this is where we hear they have challenges or they're slow to progress with chewing or eating those. They prefer non-lumpy foods because it's more challenging and it's hard to coordinate. They also have this thing that's really important when drinking and eating called the glossopalatal seal. And when it has two kind of functions. When we're closing off the palate, the tongue serves a role. Actually, it's better if you actually position it this way, is the anterior tongue tip closes off against the hard palate, as we see here at the front near the top of the teeth, to keep that bolus in the central, like holding it in the central at the top of the, against the hard palate in the mid-tongue. And then the soft palate is preventing it from premature leakage into the pharynx while we're still, collecting that into the oral cavity. And so for a child who's got either posterior tongue tie, if they aren't able to actually get contact with that velum or that soft palate, they're going to get premature leakage of that liquid when they're not quite ready to swallow it down. Similarly, if they've got an anterior tongue tie and they can't get glossopalatal contact with the hard palate and the anterior tongue tip or tongue blade, they might get some oral escape during swallow. So the tongue serves such an important role in that glossopalatal seal to prevent either that interior or the posterior spillage. I just like this study, so I like to bring it into it because we're talking about the tongue and oral movements. And Alison Bruderer did this lovely study showing that actually she compared children who had different types of teethers, which were restricting different levels of the tongue. So from no teether to having this B, where it was just restricting some side movements, to A, where the whole tongue was low-lying and couldn't get the flat teether versus the gummy teether. And actually they found for kids who were restricted and had the flat teether, so they couldn't move their tongue around, they had poorer perception, so hearing and discriminating between sounds, than children who had good tongue movements, which is really interesting. And I understand for speech production that you can't practice moving your tongue, you can't produce, but it's interesting that actually there's almost like a biofeedback system that it actually also impacts speech perception, which is really interesting. Watch this space. I think we need to have more research on this. So how do we assess these kids? And how do we effectively measure, how can we measure anterior, posterior tongue movements in these kids to effectively get that functional and that visual or structural component of assessment? And one of the things, this is kind of in my mind when I'm seeing a child, I think about my assessments of structure in terms of what it looks like and coding that against one of the Kotlow, the Carillus, the Todd-and-Hogan, one of the systems of classifying or describing what I see. And in terms of function, to me, there's two different things in function. One of them is movements isolated from oral motor tasks. So there's the ability for the tongue to make different movements, not during feeding. So isolated from feeding, isolated oral movements, and then measures of actual tongue movement during functional activities, eating, drinking, breastfeeding or bottle feeding. And so a comprehensive assessment to me should include all of those components together. And these were some babies we had using the NFAT study where we were looking at their feeds pre, post and a follow-up. This was one of my PhD students, Emma Neckers, published 2 weeks ago. This is a huge systematic review. Look, she looked at all the assessments available, and there was a few thousand of tongue structure and function for the diagnosis of ankylogloss for tongue tie. And this paper, we came with 117 studies, and this is a huge paper there's lots of tables, so go and have a read through. Overall, I'll just tell you the main finding is the lingual frenulum protocol for infants psychometrically was the best and had the most reliability and validity data, and was the most comprehensive tool we have currently available for clinical assessment. And as you can see here, because it looks at that tongue structure as well as oral motor function and feeding function. It's the only tool that did all three in a psychometrically sound way. So you can see we've got lots of assessments of structure, lots of oral motor tools, but very few that look at all three components in that triad. We can get information from our case histories, from our oral, as speeches, we do our oral motor examination and our neurological, our cranial nerve examination. And then we do a feeding trial. This is kind of standard practice in an assessment that we should all be doing. But remember, I think we have to take a step back and go, we're actually not assessing, getting kids in to assess them for a tongue tie. We're actually just doing our assessment as a whole person, and assessing the tongue structure and function is just one component of that. And so ideally, we're optimizing overall feeding, and it might be totally unrelated to the tongue tie, the lingual frenulum. These are some of the tools available. I'm sure you're all familiar with these. These are classification systems, the Carillus in 2004, Kotlow's tongue classification, 2013. Todd-and-Hogan, you might be less familiar. They modified the Carillus to describe in more detail superior, inferior attachment and describing the characteristics of the frenulum. I like they've got the 100%, 75, 50%. So David Todd, Monica Hogan's doing her PhD. Watch this space. She's got some amazing work coming out about wound healing. And this is a really nice classification system they use at Canberra Hospital in Australia. The BTAT is a nice tool to measure out of 8. You can have a look at, this really is only covering those two aspects in terms of oral motor movements and appearance. And then they've got a visual version of that, the TABI. The Hazelbacker's assessment tool of lingual frenulum function. Just bear in mind, these function items on here really are more oral motor movements than functions during feeding. We're not getting a true, most of these are actually like, what is the tongue actually, how is it moving, as opposed to during feeding. And then the appearance items. And then this is the lingual frenulum, Martinelli's lingual frenulum protocol. There are actually 2. There's one for infants and then there's one for older children as well. So this is the infant one. There's a little bit of case history. There's scores for family history, siblings, duration, timing between feeds. your clinical examination, and there's a second page with some other questions about coordination and coughing, choking. So just a bit of a case study. This was one of the kids in our study. I thought it was useful to kind of look at how things can look on each of those. We used all of those assessment tools to measure. And so pre-surgery, if we're just looking at free tongue movement, this infant was about 11 millimetres, moved to 16 millimetres. This infant actually got worse, even though this image looks like there's a lot of free tongue movement. Their position of lingual frenulum, they had a little bit of reattachment. It was at about 15 millimetres post-surgery at follow-up at 4 weeks. So they actually started at 11 millimetres, so they would have been classified as being a moderate tongue tie, a class 2, and then they moved to a class 1, and they stayed at a class 1 because it was 16 millimetres and to 15. So they never actually really achieved a clinically acceptable free tongue movement, which was greater than 16 millimetres. If we looked at the Corellis and Jenner, they moved from being a type 3 posterior tongue tie pre-surgery, but they actually also stayed there because they never moved to 2 to 4 millimetres behind the tongue tip. If we're looking at Todd and Hogan, they moved from a type 4 pre-surgery to a type 5 post-surgery and at follow-up because it was 15 and 16 mils. They moved from 11 to 15. And similarly on the BTAT, they moved from a pre-surgery score of 4 and they improved to a 7 out of 9. This is a really, really busy slide. We have submitted this, it's under review at the moment. This was a paper looking at all the outcomes using the ATLAF, the LFP, and a lot of other tools as well. But just look at numbers. And if you just look at ATLAF numbers here, there's improvements from, for example, 9.7 to 19 and then there's a little bit of slight regression to 17, but still a very statistically significant improvement. The LFP scores, I'll go the other way. So these infants overall went from 11.9 down to 4.8, down to 3.8. So the symptoms resolved in terms of the history, reporting, the clinical evaluation, and the observation of feeding. And this is pretty consistent across our clinical measures, and you can see similar things happened with the symptom checklists. There was improvement from 18 down to 10, down to 9, and also the NEO-EAT. There was improvements as well. So we can see here, and then improvements in that NEO-EAT score reduced over time. So if we pull that all together, pre and post surgery, there was improvements in the ATLAF from 9 to 19 to 20 overall for this one case, and improvements, remember, it's the other way around, from 9 to 6 to 3. So when we're looking at function, we can be asking the parents and do a parent report, the infant eat or the NEO-EAT. NEO-EAT's a longer version. The infant eat is a new tool that came out last year in 2024. It's a shorter version for infants under 7 months. So we can ask questions as part of your case history questionnaire. I really like Richard Baxter had some on his website. I don't know if they're still there. And Larry Cotley does too. Then you can actually do some feeding function assessments using the Breastfeeding Initiative tool or this Early Feedings tool as well. For older kids, this is a really amazing, simple test, if anyone's familiar, the test of mastication and swallowing solids. And I often say this is a really cool tool. If I say this to my dental colleagues and they say, I'm not going to get kids to eat crackers in my dental practice and make a mess. But there are norms. You could ask, it was started, they collected norms on adults aged 20 to 80, and you can measure based on eating a cracker, and there's different crackers in different countries around the world and different norms. For each cracker, they've worked out how many bites it should take the people, how many chews or masticatory cycles, how many swallows, and how long to eat that cracker. So in Australia, we call it an Arnott Salada cracker. And we've got now norms for adults, but we've also, Frank and colleagues did some normative data on their crackers in 4 to 18-year-old children. And then myself with one of our honours students, we did some normative data which were published as well on 2 to 4-year-olds. So there are actually norms of how many bites, how many chews and how many swallows, all the way from 2 to 80 years of age on crackers in different countries, which is pretty cool. So we can see a function of eating function over time and how that changes. You might get asked for a baby when they come in the clinic. Parents are often worried what happens, are they going to have speech problems later on? And this was a study we did back in 2020 where we had kids who had tongue-tie treatments as infants in the first 6 to 12 months of life, and the children who had tongue-tie but chose not to have treated, so untreated tongue-tie, and those controls who didn't have any tongue-tie. We followed them back up between 2 to 4 years of age, 2 to 5 actually, it was 2 and 4, 11 years of age, and did a speech sound assessment on all of those children, a comprehensive speech sound assessment on 59 children. And we actually found there was no statistically significant difference between measures of speech production, intelligibility, or tongue mobility in this robust assessment of these between those groups, between these 59 children. There was a group of kids who were untreated who had more history of having speech pathology services, but we found that wasn't specific to articulation deficits of sounds associated with tongue mobility issues necessarily. They also had speech pathology for fluency and language issues as well. But it'd be really nice if someone does a prospective, a larger study with more than 60 babies and children as well, and followed them up. So in terms of treatment, now I'm overstepping the mark. So there's only a couple of slides on surgery because this is not my jam. So as a researcher, I'm going to report on this and the research because I don't do surgeries as a speechy. But what I will report on is this is a systematic review of surgical approaches to tongue tie, which looked at different types of surgical procedures, scalpel, laser, and scissors. And they found that the literature still doesn't show that there is, and Z-plasties as well. And of the 35 articles in here, they found that actually there's lots of heterogeneity in the population, and all the 7 RCTs in here were actually of a really low level. And they found that actually some of the studies showed that breastfeeding outcomes improved, but it was subjective maternal reports only. But overall, there was no clear advantage of one technique over the other. And in fact, it can be the individual practitioner. It's more important than the actual surgical approach. And we talked a little more about certain non-surgical approaches previously as well. This paper by Miller, which was published earlier this year, February this year as well, was compared scissors and stretchers, which was interesting. They just found that stretchers didn't cause more pain in the baby. Sorry, this is looking at stretchers and scissors. Sorry, it was looking at stretchers and outcomes, whether stretchers improved outcomes. And they actually found that one of the biggest factors is parents and them actually adhering to doing the stretches, because the babies that didn't have stretches, 16% had persistent problems compared to 0% who did their stretches, and 32% of those who didn't do their stretches needed to have another procedure. This is one of the case studies that Ray and Jessica and I published, I think, last year. It was a really interesting one of those kids, a case study of a baby who had a sequential, so had their lip tie procedure, then we could measure resolution of symptoms of the lip tie, then had the tongue tie procedure, and then we could see resolution of symptoms of the tongue tie. So we could actually correlate which symptoms were related to the lip and then which symptoms were related to the tongue. And then when both were conducted, there was some symptoms that improved overall, another 3 symptoms improved and 1 kind of stayed the same. So that if you wanted to look at that, that's we can read that in more detail as well. Myofunctional therapy, this really is, we should be, myofunctional therapy, I think we need to clearly differentiate between babies and older children, because true orofacial myofunctional therapy we shouldn't be doing for children until over 4 years of age, until they're cognitively able to actively make report and make changes and engage in activities. So I think the term myofunctional therapy in these studies was not clearly defined, whether it was feeding therapy versus true orofacial myofunctional therapy, because they've actually reported improvement in breastfeeding duration. To me, that's not orofacial myofunctional therapy, that's feeding therapy. Over the last few years, we've been doing a little bit of work, or a lot of work in pre and post-operative care for ankylosing. And so I think that's another really important thing that we're still working on. We know that strengthening and stretching the tissue improves tongue mobility after frenectomy. We've seen that with the scissors paper as well, that there can be some reattachment and less optimal outcomes. And we know that active wound managements can help prevent that reattachment and optimize healing and promoting neuromuscular re-education. And Robin Merkel-Walsh and Laurie Overland, their work and their book and Robin's work in neuromuscular re-education is really important, significant. But we do know that what people are doing in practice is very variable. And even between countries and states, there's high variability in practice. We did a systematic review to look at all of the papers looking at pre and post-operative care. And so this paper, if you're interested in all the perioperative outcomes up to 18 years of age, we found 23 papers. And so we've mapped on here each of the papers that included speech pathology, myofunctional therapy, analgesia, use massage, breastfeeding, or other outcomes. And you can see here there's dots here, whether it's pre-operative or post-operative care. So you can map which studies and then what their adherence, whether they reported adherence, and then what were the outcomes. So have a read if you're interested in more information about that. As a result of that review, we went, okay, how can we use the evidence to actually create our own? So over the last few years, we've been actually, as the basis of that evidence, we developed an evidence-based protocol for infants, and we've got a website going. So we've got some videos and photos of our final prototype. We then got some feedback from families, from clinicians and families around the world, about what they wanted. And so we got some engagement with Australian mums about their how they felt that the protocol was working. They gave us some very good feedback about what we need to do. And then this is a summary of what they found, and that was published earlier this year, that we know that parents are an integral part of that process because they're the ones doing the exercises, 3 to 4 hourly, multiple times a day, but there are variations in their abilities, their skill level and ability to comply and actually do it every 3 or 4 hours, and adhering to the types of exercises that are prescribed by the provider. And what they found is that, so when we looked at the feedback, they gave us some really good hints and tips about what they want and need. And they wanted lots of follow-ups. They loved having a Facebook page, being able to touch base with their provider and send photos and get live feedback. They needed that reassurance, was really important to them. We've actually now pilot testing. We've updated the website based on the feedback, and we've got families who are tracking pre, post, and follow-up data using some of those validated tools. And then we'll be rolling that out to multi-centres as well in a few years. This is actually very fresh, hot off the press, just 2 days ago. Actually, no, that was yesterday, my time. as part of ICAP and the Serious, we've now got a research network, Serene. And so Bryn Leroux and here's Duke, Bryn's in Louisiana, and Dr. Duke, who's a dentist in Quebec, and Ray is in North Carolina. And so we're actually got some multi-centers. We're going to be tracking outcomes of infants with tongue tie from multi-center trial. So we can have lots of, instead of getting from one site, we're going to get some big data now. So we thank these sites for being our pilot sites. So we've got 2 minutes to go, just before in time. I was going to say, part of the research that we're doing and ongoing, there's lots of research happening, wouldn't have happened without these collaborators on this ICAP page: Andrea Kittrell, Ray Tseng, Robin Merkel-Walsh, myself, Natalie Jones, and Jessica Altamara and Jimmy Chan, and particularly my partner in research and crime, Ray. And then this is our scattering of all the students that Ray and I've supervised over the last couple of years as well. So there are some references on here which you're welcome to see. I'll open it up to questions now, and I'll stop sharing my screen. That was like a whirlwind of swallowing and feeding and assessing from an SLP.
Much needed. Oh my goodness, that was wonderful. Thank you so much. If anybody watching this live, if you guys have questions, please put them over here for us to see. Let me open up my questions. I know that I have many. What a wonderful presentation. So much research. Let's see. I have too many windows open.
I can't see any at the moment.
Found it. Okay, found it. All right. Can you describe, and some of the things, let me warn you guys first. Some of the things that I asked was already covered in the lecture. However, I'm asking so we can put this on social media, then people can come and listen to the rest of the lecture.
No worries.
Can you describe the role of orofacial myofunctional therapy in managing tongue tie and supporting optimal feeding outcomes?
Yeah, so to me, there's a differential between true orofacial myofunctional therapy and feeding therapy. And so feeding therapy is within the scope of practice of speech language pathologists and occupational therapists in the United States, I believe, less in Australia. And so to me, between 0 and 3, particularly 4 years of age, that really infants who we're seeing for issues with feeding function and tongue mobility should be seeing a speech language pathologist for feeding therapy, a feeding specialist over those years. When there's more active engagement and the children at an age that they're able to follow instructions and engage in that active movement and patterning and following instructions, which is usually, I mean, to be fair, I have seen some 2-year-olds who are able to engage, but typically it's not until our kids have adequate coordination and adequate cognitive skills, which is a really 4 years of age we can pretty much guarantee, or some of them 5 years of age. So really I kind of use 4 years is that, for me, the critical age that I kind of differentiate. And we're doing a review at the moment on OMT and feeding functions and outcomes, and we've actually limited it to 4 years plus.
Amazing. As a professional and then as a mom, how do I recognize that my child may be having a feeding issue versus a myofunctional issue?
I think it's a really grey area between the two, because some of those symptoms that children present with OMDs are actually overlapping with some earlier feeding difficulties that have manifested in long-term oromofunctional disorders, and vice versa. Some children who probably had some muscle challenges and weaknesses and in coordination earlier on and compensations for, and then they have some long-term feeding challenges as well. The chicken and the egg, isn't it? So how do we differentiate between whether it's a feeding, I would be an age, I would say go and see a feeding specialist as early as you can.
Okay, so that's like if they're not gaining weight, if they're avoiding all textures, if they are choking when they're swallowing, things like this is what I'm looking for.
Yeah, so I would say in an infant, if they're not gaining weight, they're dropping centiles, they've got poor suck-swallow coordination, feeds are taking more than, well, an hour, 45 minutes, then it should be down to half an hour for a bottle or breastfeed. They can't sustain. They've got anterior oral scape. They're coughing, they're choking, they're clicking early on. That critical when they're not starting solids, if they don't transition to solids adequately and these are the kids who might have a preference. Well, there's a differential between those kids who are fussy eaters or have true, ARFID or food restricted intake disorder versus kids who are just, those picky eaters. And there's a normal variation. So working out those kids who have poor coordination and genuinely are coughing and choking and gagging because of physiological issues or dysphagia or pharyngeal or orofacial dysphagia compared to those kids who are spitting out because they don't like the taste or the texture.
Yeah, it's so important. I'm glad that you brought the scope of practice. It's so important for us to stay within our scope. As a dental hygienist, we can do nutritional counseling. So there's a lot that we can do with that as long as you don't pass the oral phase swallowing. It's so important to recognize when there is an issue that you cannot handle and to be able to send to the proper professional who is actually trained in doing so. In Brazil, it's only speech pathologists that do orofacial myofunctional therapy. And I have seen some cases of little ones, and I'll message them and I'll ask, okay, what did you do here? And they will say, we just did myo, but it looks slightly different. Like you said, they don't know how to copy what you're doing. So it's more of a manual. You're helping this child make these movements and things like that. So again, scope of practice, do you have the license to touch? And I think that Robin Walsh says that that's more oromotor therapy. So even if they don't need feeding specifically, it could be oromotor, it could be something different. I don't see little ones because I only work online. I feel like little ones really need that one-on-one. They are not going to just sit there and do exercises. I can make some recommendations of what's healthy for breathing and for, things that you can do at home as a parent and games that you can play. But more than that, I'm not qualified to do. I did have one 3-year-old that was the most incredible mature patient.
Right.
She would sit there and she would do the exercise. And I was like, oh my gosh, but my 5-year-old won't, so it's very child dependent. You have to really evaluate everybody differently. If there is a myofunctional therapist here or somebody who practices myofunctional therapy and a parent is reaching out to them, be that person to, welcome them, listen to their concerns. And if it is something that is out of your scope or something that you're not trained to handle, that's why we have Area Circle. We have a list of incredible professionals all over the world that we can collaborate with as other professionals to be able to better treat our patients. With that, I'm going to go into how do you with your multidisciplinary teams, including speech pathologists, lactation consultants, collaborate in the management of tongue ties. So how does it work? I know that in Brazil, we barely have IBCLCs, which is International Board Certified Lactation Consultant. Even IBCLCs don't have much training in tongue ties. Most of them don't, unless they go to look for more, In Brazil, speech pathologists are the ones checking the babies, and the passed the law, Roberta Martinelli, one of my good friends, that passed that law. And by the way, it just arrived. I have to show you guys. Tongue tie in Portuguese, translated by
Portuguese, sorry.
Yeah, so anybody in Brazil, you can get it on Amazon. It has to be America Amazon, by the way. So super excited about this work that Dr. Baxter allowed me to help translating and get it to Portuguese speaking families. But I know that
you can go and have that image in the book.
Yes, I know it's different in many places. I'm not sure how it is in Australia with who is trained to treat babies, who it's not, who is trained to do lactation. I know as a dental hygienist, I can also, or any professional, I think you can go into lactation and get your lactation consultant and your IBCLC. So you have more training with that specifically. But how do you in Australia work with lactation consultants?
Yeah, and certainly having worked at the Tertiary Children's Hospital on the feeding difficulties team and at 2 hospitals here in Perth, We get referred children from work in the neonatal unit all the way through to inpatients and outpatients in the general paediatric wards. And so, but to me, I will see the baby, and typically, unfortunately, the babies that I failed, and so they're typically bottle fed or combination bottle and breastfed. And so for me, I'm looking at the infant from what is the infant's oral structure function. As soon as it comes to anything to do with the lactation aspect, I have the lactation consultant or the IBCLC, who I inpatients-wise call them down to the ward to see them, or I would be referring. I have my preferred providers who I know are absolutely on top of the evidence, and they're not over or under diagnosing the babies with tongue tie, and they are triaging the breastfed babies and providing that non-surgical management. And so I think it's about finding your tribe, isn't it?
Yeah.
It's finding those people you have confidence and you have good cross-referral systems with, and that you have faith in their approach and their values and how they approach management. And even the local dental providers that I work with who are very conservative. If there's a child over 12 months, they send them all, or actually even over 6 to 9 months. If they've started solids and they're saying we want to have a tongue tie now, they will send them to me. They sent them to me and say, can you look at their eating and drinking and check their whether they actually are, and for feeding purposes, are they a decent candidate? Do they actually have a functional deficit that's indicated by tongue tie, or is it just a feeding deficit? And so that's my role is I'll work with them, give them some therapy for a block of time and work out, is this truly a tongue mobility due to the lingual frenulum, or is it just a feeding delay that we can work on with that non-surgically?
Perfect. Are there any recent advances in research or clinical practice that have changed how tongue tie is managed in infants and young children?
Management. Is there things that have changed management? I think we're getting a little bit better at assessment. In terms of treatment non-surgically and surgically, I don't know anything majorly different that's been, I mean, probably still the gold standard is frenectomies, and whether it's, and I think with the jury's still out on what's the most optimal type of laser, whether it's scalpel or scissors, and there's the age-old debate, is one better than the other? And then I don't have to do exercises if I do scissors or scalpel versus doing a laser. And I'm overstepping because I'm not in terms of, but I'm going to say from a pre and post-operative exercise, because that is in my scope of the oral exercises, and not the surgical approach, is it depends on the individual. So I'd be looking at that individual and their recovery. And if they look like their tongue mobility is starting to get restricted and they've got maybe one unilateral, they've got poor movement, I'm going to be working with them to try and optimize movement. And whether that's passive during breastfeeding function or bottle feeding or eating and drinking, we just want to get the tongue movement, or whether it's palpating to actually get some that elevation and not reopening the wound, but at least getting some active movement. And yeah, so I'm going to say, is there any advances? I would say yes, in pre and post-operative care. Maybe we've got get a knowledge in how to manage that. Yes, there are some papers now that tell us how to do our pre and post-operative.
There are some controversies in Brazil. Over there, they don't do pre-op for tongue tie releases at all. The child just goes straight for release. They do it's not the TRMR, but it's the one that Marquesan came up with, that you do elevation of the tongue and then suction, and you get, if it's 50%, then they do the release. They only do that. And if it's altered, they call it altered, then they do the release, and then they do therapy afterwards. Many of them are still not doing sutures. However, in Brazil, even babies, they numb them. They give
babies
them
what? Sorry,
numb. They numb.
No, they numb. Yeah.
So babies lay on top of the mom, and they actually give the baby a shot. on the little tongue so they're not in pain. I think that that's wonderful. It takes longer, but I think that that's wonderful. Even though afterwards is it going to be more difficult for them to nurse because they're numb, you know. However, the mom, I'm like, I don't want it to hurt. Do you mind sharing a little bit what you mentioned about the stretches, what the research, recent research found about doing stretches or not?
And it's interesting, stretches. It's funny, we after the latest ASTOC conference, I was at the we were at the pub and we were having a talk about whether they're stretches or whether it's just movement or whether it's palpation or what do we call it, because stretches assumes that we're reopening tissue necessarily. So is it stretching or is it just
stretching?
Is that stretching or is that exercise? So that's a stretch.
That's a
versus an exercise.
Exercise is different. Exercise is, I wanted to be on that conversation.
And so we ended up coming up with words like, should we call it strexercises or something? Or come up with a funky term for it. And so I think you're 100% right, is the jury's still out on pre-op exercises. Is it just about a sensory opportunity? Is it more about preparing the parents for what to do, where to position your hands, what pressure to apply without knowing there's a pain or a surgical element, is getting them used to getting fingers inside mouths. So is that more important than the actual exercise versus post-operatively where you are actually trying to keep that tissue from reattaching? And I don't think and that's the very nature of phase 4 of our study, is where we can actually have a group of pre-op only, post-op only, pre and post-op, and no exercises, because we don't know that exercises are actually, and if we have all 4 groups having the same surgery with the same technique, with the same provider, we can, and with the same outcomes we're measuring, there's going to be some variability in age and obviously presentation and type and classification. But if we can look at those 4 things and adherence, that with some big data, then that'll help us, give us a better idea, I think, of a standard protocol.
Sign me up. I want to help you.
Yeah, but that's going to take a bit of time.
Yes, we definitely need more research. This is much needed conversation. Thank you so much. I know that I have so many more questions in my mind, but I can't ask them right now because we're out of time. And you guys, I just forgot wearing new t-shirts. And Blau, our speechy on Every Circle, came up with this phrase. So we put on a t-shirt and they are on, we have a special right now in the Every Circle store. If you get a shirt and one of the new cups, we'll have a limited edition, really cool cups that are on pre-order. So those are arriving in about 2 weeks. It's going to be a minute before you receive them, but the t-shirts have arrived. You get $5 off. So do the code pre-order. And this is what it looks like when the tongue lifts low. Thank you. And there's V-neck. So they're a first V-neck shirt. So many people ask me for V-neck. They're super stretchy. This is a size small. I'm about a size 4 or 6. So this is a size small, and it fits super well. It's super soft and breathable. So you guys run over and get your t-shirt. Thank you guys so much. Dr. Sharon, what a wonderful presentation. We appreciate you. Last words, and how can people reach out to you? Do you have any courses, books, anything, conferences you'd like to share?
Yeah, so we'll be at Tongue Time or IOM, which will have already passed by the time you've watched this in September. If anyone's going to Salt Lake City, we'll see you there. Yes, of course.
And I'll bring some t-shirts. So if you're in Australia and you can't get any shipping, let me know.
That is fantastic. And the best thing about being part of a university, I'm fiercely independent. So I don't run courses. There's no profit. It's purely out there for the community. So happy for people to reach out to me, Instagram and on Twitter. But also people who are involved. I like building capacity. If clinicians are interested in research, contact me and see how we can work together to help your practice to build some of the research and curate it yourselves.
That is wonderful. Thank you very much, everybody. Have a wonderful night, and we'll see you next week. Bye-bye.
Thanks, Renata.